I have always found hip pain to be one of the most complicated and challenging topics. So I'm hoping that today I can help simplify it a little bit for you. And so that's going to be my primary goal today, is to demystify hip pain. So in terms of my objectives, we're going to learn to identify and diagnose the most common causes of hip pain in the outpatient setting, determine which physical exam maneuvers might help you differentiate between the most common hip pain diagnoses, identify some imaging necessary in the workup of hip pain, and also prescribe the appropriate treatment for the most common causes. But my true objective is to get you from feeling like Tommy Boy to more like Jack Donaghy. And I just wanted to get a sense for, the screen looks a little bit funny, I'm hoping this works, but I just want to get a sense for how comfortable everybody feels with hip pain. Some of you might say, you know what, I see this all the time in my practice, I actually feel pretty good about it. Some might say like, oh, I just sort of move the hip around a little bit and then send them to physical therapy, but I have no idea what actually is causing it. Honestly, most of you probably don't have time to address it, these MSK complaints, so you just refer, and then there might be a few of you who don't even know what the hip is. Let's see if this works. Oh, good. Oh, good, it's working. I hope you all don't feel like you've mastered the topic. I don't know how many people respond. I'm not seeing it here either.
Like a little counter down here.
I'm scared to touch anything. I know. It wasn't mirroring before.
Oh my God.
Yeah. Fewer people have mastered it.
5 seconds.
All right. Okay, so I decided to end when it seemed like more people didn't feel comfortable with the diagnosis. So it looks like actually, many of you feel comfortable with it. So I think that's a good thing. And hopefully for those of you who feel like you're just sort of sending people to physical therapy without really knowing what's going on, hopefully this can be helpful for you. And it seems like everyone knows what the hip is, so that's good. And then I liked this question because, you know, patients come in with, when they come in with hip pain, it's like not just in one place. Sometimes it's in the front of the hip, sometimes it's on the side, sometimes it's in the back. So where do you guys think the hip is located? Is it in the front, the side, the back? Okay, so most of you think it's in the front, and I would agree. When people come in with hip pathology, they're usually going to present, or they're going to complain of pain in the front of the hip. But I also want to show this slide, which is basically shows you, people who are coming in with hip pathology, where are they complaining of pain? So most of the time it's in the groin or anterior hips, 88%. But there are plenty of people who report lateral hip pain when it's coming from the hip, or low back, or buttock, or anterior thigh. So you really can have people coming in with a variety of complaints, and the pain is actually coming from the hip. And that really highlights one of the reasons why hip pain is so difficult.
Why the knee? Is that because they change their gait now the knee hurts?
Yeah, most of the time when I see knee pain, it's usually really bad arthritis. That's kind of being referred to the knee, and probably some relation to compensation, limping, those types of things. So just kind of I want to do a brief review of the anatomy. I think with musculoskeletal complaints, it's probably where anatomy really becomes important. So most of you probably know these basic things already, but here's your femoral head, and then the acetabulum, which is the socket. So ball and socket joint, as we know. And then right here is the femoral neck. This is the greater trochanter. So that's the bone that you feel on the outside of the hip. And then on the right here, I've just showed the labrum. So the labrum is a little piece of cartilage that goes around the rim of the socket, and it helps deepen the joint. We also have one in our shoulder. And then I'm going to talk a little bit about that later in the presentation. And a review of some of the muscles. So looking at the posterior aspect of the pelvis here, you have the gluteus maximus here, the gluteus medius right here. And then on the lateral side of the hip, you'll see we have the tensor fascia lata is up here, and then it kind of turns into the IT band, which most of you are familiar with. The gluteus maximus is here again, and then under this fascia is the, gluteus maximus here, and under this fascia is the gluteus medius. And then I'll just mention the rectus femoris right here, which is in the front of the hip, and that's one of our hip flexors. The iliopsoas is also deep in the pelvis and is one of our hip flexors, and then we'll get to that a little bit later as well. So I think hip pain can kind of be boiled down to three of the more common causes of hip pain, and this is probably what most of your patients are going to come in with, one of these three things. So, osteoarthritis, coming in with groin pain, it can radiate into the thigh. Greater trochanteric pain syndrome is usually more lateral pain, and then lumbar pathology or radiculopathy often is more posterior hip pain or buttock pain, and can radiate into the leg. So I'm going to go through a few cases to kind of demonstrate these causes of hip pain. So a 62-year-old woman comes in with hypertension, obesity, reports insidious onset of right groin pain. It started about 6 months ago. There was no injury, but it's getting kind of progressively worse. Radiates into the thigh. She says it's worse if she sits for a long time or walks for a long time, and it's becoming harder to put socks on or pants on. She's tried taking some NSAIDs for it, which helps kind of temporarily. So, someone coming in with groin pain, they're over the age of 50, you're kind of thinking maybe this is arthritis. So, and this woman who comes in, this is probably the physical exam that I would perform. So, log roll, which is demonstrated up here. And that's basically exactly what it sounds like, sort of rolling the leg without actually moving the leg or abducting or adducting. And that's pretty sensitive for intra-articular pathology. So if a patient has pain with log roll, it's probably coming from the hip joint. Passive hip abduction is kind of similar if they have pain with that, and it's just kind of because it isolates the ball in the socket, and you're just sort of moving the ball around in the socket without affecting many of the muscles in that area. And then I'll check their range of motion. So flexion, and then internal and external rotation should be, that should be right here. You should put the hip at 90 degrees, and then that's how you can check their internal and external rotation. And it's helpful to know kind of what the norms are, but what's most helpful is comparing to the norm, to the patient's other side. It's going to be a little bit different for everybody. So that's where you can kind of note some differences, is if it's different than the kind of unaffected side. And then someone who's got groin pain, we mentioned that the hip flexors are kind of in the front of the hip there. So I find it helpful to do a resisted straight leg raise, which is basically testing those hip flexors. And if they have pain with that, sometimes that's consistent with a hip flexor tendinopathy. So this woman comes in, she's got pain with log roll, some restricted range of motion. What would you do next? Would you get hip x-rays? Would you just say, try some medications, anti-inflammatories, maybe go to physical therapy, and then, or, you know, I don't know, see ortho, I'm like worrying about her blood pressure. And this is a safe space, so you should feel comfortable to answer anyway. That's the truth. Doesn't have to be the, and actually there probably is no wrong answer here. Like most everyone's getting hip x-rays. Okay, some people would send right to physical therapy. I mean, maybe you have x-ray in your clinic, maybe you don't, maybe the x-ray tech is out, and so or maybe there's a long line, so you're kind of like, do I need to get x-rays before I can do anything? So it sounds like most of you would get hip x-rays, some of you would send maybe to physical therapy first. So I think, you know, if the patient's older than 50, it's reasonable to get x-rays. You know, the common diagnosis is going to be osteoarthritis, which you of course would see on the x-ray. If they've had any trauma or they're having difficulty with bearing weight, that would be another time that I would consider getting x-rays. But I don't think it's necessarily wrong to try some physical therapy first. When I get hip x-rays, I like to get the AP pelvis in addition to the affected hip. And then right here, these 3 x-rays kind of demonstrate the 4 hallmarks of osteoarthritis that I'm looking for on an x-ray. So joint space narrowing is one of them. So you can see here's kind of a normal joint space and it's getting more narrow over here. So that's one thing that you'll see in osteoarthritis. In this view, you see some osteophytes as well as some sclerosis. So this white is the sclerosis. And then this x-ray on the far right shows a subchondral cyst. So those are the things I'm looking for on x-ray when I'm diagnosing osteoarthritis. It's joint space narrowing, osteophytes, sclerosis, and subchondral cysts. So those are the things that you're going to be sort of using to help make that diagnosis. So in osteoarthritis, it's common, you know, prevalence of symptomatic OA is about almost 10% in adults over the age of 45. It tends to be more common in men under the age of 50, and then over the age of 50, it's more common in women. Risk factors are what you would expect: age, obesity, certain occupations. It's very common in farmers. And then anyone who has had hip surgery in the past, if they had hip dysplasia when they were younger, they're going to be at increased risk of osteoarthritis as well. And then in terms of treatment, you know, I really try to keep people active as much as you can. So really focusing on low impact exercise, aquatic exercise can be helpful, and having them kind of avoid aggravating activity. Physical therapy can be helpful. It tends to be more helpful in early, more mild osteoarthritis than it is in sort of more advanced end stage arthritis. And then I like this little fact here. So weight loss, of course, we always recommend weight loss, but an increase of 10 pounds of body weight puts an additional 60 pounds of additional pressure on that hip with each step. So I think that's really helpful information to know. And you can kind of use the reverse of that with patients. So you lose 1 pound and you're taking 6 pounds of weight off that hip with each step. So even small amounts of weight loss can really help take pressure off of that hip. And then of course, you know, medications, sort of short term, can be helpful. Acetaminophen. Topical NSAIDs tend to be a little less helpful with hip OA just because it's the joint is relatively deep, you know, compared to knee osteoarthritis. And oral NSAIDs, actually diclofenac, I guess, is the most efficacious in hip OA. And I don't know why that is, but something to think about when you're sending your patients out with NSAIDs. And then of course, if some of these more conservative treatments aren't helping, then you can always try a corticosteroid injection, which I do those injections under ultrasound guidance. They can also be done under fluoroscopy. So I do want to touch on groin pain in a younger person because we all have younger patients in our practices as well. So the differential, of course, is going to be a little bit different in someone who's young. They're going to be less likely to have osteoarthritis. But what I'm thinking about in someone who has groin pain in a young person is femoral acetabular impingement, or FAI, which we'll talk a little bit more about in a minute. Maybe a labral tear. And both of these diagnoses you can help support by doing the physical exam maneuver called FADER, flexion, adduction, internal rotation. And that's demonstrated here in this picture. So it's exactly what it sounds like: flexion, adduction, and internal rotation of the hip. So when that causes pain, you might be thinking, okay, FAI or maybe a labral tear. Hip flexor tendinopathy is another thing we'll see in young people, especially in people who are really active. As mentioned before, I would do the resisted straight leg raise to kind of help support that diagnosis. And if they've got pain with that, that would be consistent with that. And then in my kind of sports population, stress fractures tend to be common. So femoral neck stress fracture in someone who's maybe an endurance runner, recently increased their activity quite a bit. They're, they kind of have the female athlete triad. And what I usually do to help make that diagnosis is a hop test, which is exactly what it sounds like. I have them hop on that leg just once. And if that causes pain when they land, that can be pretty sensitive for a bone stress injury. So femoral acetabular impingement, I feel like I had no idea what this was until I went to fellowship. So I thought it might be helpful just to talk a little bit about. And especially I think in medicine, we think impingement and we think nerves. So yes.
There's no pain.
You know, that's why I just have them do it once. There are some people who will say, I can't hop on it. And I don't force them to do that. But yeah, I mean, they're going to tell you if they can't hop on it. And then to me, that's a positive hop test if they refuse to do it. And of course, yeah, if people are coming in and they're really limping, it's pretty obvious to me and you don't have to do it. So basically what impingement, femoral acetabular impingement is, has nothing to do with nerves. It's abnormal contact between the femoral neck and the acetabulum. And this you can imagine if the ball is kind of hitting up against the socket, because that labrum is right there, you can get labral tears. It can increase your risk of osteoarthritis. And there's two causes of impingement. So there's the cam impingement, which is where you have kind of a bony prominence here. And then there's the pincer, which is here on the left. And that's where you have kind of over coverage of the femoral head. The cam impingement tends to be more common in young athletic males, whereas the pincer impingement is more common in active, sort of middle-aged females. Probably the most common is a combination of those two. So a little bit of pincer, a little bit of cam. And then this is where, if you're suspecting FAI, an x-ray can be helpful because you often can see the cam deformity or the pincer impingement. So here, the femoral head and neck junction, I don't know if everyone online can see this, but usually the femoral head neck junction comes down like this. And it's kind of like an apple core, if you think about it. But here it's much more sloped. So you can imagine if you move that hip in certain ways, there's nowhere for the acetabulum to go. So it just sort of hits up against each other. This x-ray on the left shows the cam deformities, which are pretty obvious. And then on the right hip here, looks like there might be a pincer form of impingement as well. You can see kind of a prominent acetabulum right there. Those are the things I'm going to look for on imaging in someone who is coming in with FAI symptoms. Oops. Yeah. They can be both. So sometimes, oh yes, so the question was, are those acquired deformities or is it something that the people are born with? And it can be both. Sometimes that's just the way their hip is shaped, and other times people develop degenerative changes, especially with that pincer deformity. You can imagine like a big osteophyte there, or an osteophyte at the femoral head neck junction. So it could be both. The treatment for this, activity modification, that's kind of an obvious one. Don't do the things that make it hurt. Physical therapy is helpful, and anti-inflammatories as needed. And so I usually try, before even getting advanced imaging, I usually try physical therapy first. And then if the patient comes back after 4 to 6 weeks, then I think it's reasonable to do an MRI. And what you're looking for on the MRI is sometimes you get a more detailed view of what the impingement is, like what the cam deformity looks like, what the pincer deformity looks like. But you can also see if the labrum is damaged as well. And then if I see that and they failed conservative treatment, then I might have them see a surgeon. And what the surgeon will do is they'll kind of shave down those, the cam or the pincer, and then if the labrum's torn, they can repair the labrum. So moving on to the next case, 73-year-old female who has osteoporosis, come in with left lateral hip pain. She said it started a few months ago, no injury. It's worse when she stands after she's been sitting for a while. Sometimes it radiates down the thigh. It's painful when she lies on that side at night, and NSAIDs help a little bit. So this is starting to sound a little bit like greater trochanteric pain syndrome, right? It's lateral pain. It pretty classically hurts when they lie on that side at night. Sometimes it hurts when they lie on the opposite side. And the reason is because that affected leg is kind of putting tension on the IT band there. So that doesn't rule it out if they say, actually, it hurts more when I'm lying on the other side. And then standing after prolonged sitting is pretty classic, or pain going up and down stairs. And the physical exam I would do for this patient, I kind of check their range of motion. And then when I palpate the greater trochanter, I usually have them lie on the unaffected side. It's a little bit easier to sort of identify the greater trochanter in that position. And I'll find that, if I have them on their back, I can't really reproduce the pain, but once I get them on the other side, it's a little bit easier to find that tenderness. And then Faber, flexion, abduction, external rotation, is shown here in the bottom right corner. I think we all think of that as a test for the SI joint, but that can actually reproduce pain from greater trochanteric pain syndrome as well. It's just a matter of asking where the pain is. That hurts. Is it in the back? Maybe that's more SI joint, but if it reproduces pain on the side, that can support greater trochanteric pain syndrome. And then since the pain is lateral and it's kind of radiating down the leg, in this patient, you might consider doing a lumbosacral exam. So you're thinking maybe this is greater troch pain syndrome. What would you do next? Would you get x-rays? Same options as before. Would you try medications, physical therapy, or send to somebody else? Because I've been working on getting her started on a bisphosphonate. So looks like the majority of you will send to physical therapy. Nobody thought they needed to get x-rays, which is great. And then some of you thought maybe doing some anti-inflammatories or medications. Nobody's referring to ortho. That's great. I think for x-rays, I coming from a sports background, I probably err on the side of getting x-rays more than the average person. And I'm at Lowry, so we have x-ray in our clinic, which sort of changes, I think, that decision. So I think you can consider x-rays, and especially in someone who's over the age of 50. And what you're going to be looking for, one, greater troch pain syndrome tends to be more common in people who have osteoarthritis. So if they've got osteoarthritis, that might help support that. The other thing you might see is in this picture, you can see some calcific tendonitis. So you see the calcium on either side, adjacent to the greater trochanters there. So that might be something that you see on x-ray. I don't think it's absolutely necessary to get x-rays, but I don't think it also wouldn't be wrong to get x-rays, and this is what you might be looking for. So you notice I've been using the term greater trochanteric pain syndrome. We're sort of moving more to this term in general. We used to call it greater trochanteric bursitis. But it's really not just bursitis that's causing the pain. It's a kind of a collection of three things. So maybe some bursitis, but probably not as often as we used to think. A tight IT band that's rubbing against the greater trochanter, and then gluteal tendinopathy. So those gluteal muscles attach right there at the greater trochanter. So when you've got sort of inflammation of those, that's going to cause pain in that same area. So it's really a collection of those three things. Hard to really differentiate between those three in your physical exam. So greater trochanteric pain syndrome is sort of what we're calling it now. Its prevalence is about 10 to 25% in people who are in their 30s to 50s. It tends to be more common in women. And then the treatment, you're avoiding aggravating activities, some activity modification, like probably patients will sort of do this on their own, but sort of start using a shorter stride that can kind of help keep that area from getting irritated. And then physical therapy. So when there was a study done, and I find this really helpful because it just demonstrates how you have to manage patients' expectations. So the satisfaction with recovery in using physical therapy was only 7% at 1 month. It was only 41% at 4 months, and it was 80% at 15 months. So it's not something that's going to get fixed or feel better in 4 to 6 weeks of physical therapy. And of course, I don't expect the patient to go to physical therapy for a year and a half, but I think it's important to just remind them that these are exercises you're going to have to continue to do, and it might take a while for it to get better. Managing their expectations is the best way to kind of keep them satisfied with their treatment and not have them coming back kind of saying, hey, I did 3 sessions of physical therapy. It's been 4 weeks. I should feel better by now. So I thought this was kind of some helpful data. Greater troch pain syndrome, topical NSAIDs can be helpful. It's pretty it's more superficial. So I have them use the topical diclofenac frequently, and oral NSAIDs, of course, can be helpful. If they have failed conservative treatment, or if they're having a lot of pain at night, they're not sleeping, or they're having so much pain, it's hard to participate in physical therapy, I'll consider a corticosteroid injection. Yes? So that study didn't compare no physical therapy. Well, it compared it to corticosteroid injections, and actually the satisfaction was better with the physical therapy than it was with the corticosteroid injection. Doing nothing, I don't know what doing nothing was. Are they just getting better because time has passed? Right. So yeah, corticosteroid injection is an option if they're having severe pain or they're not getting better with the conservative treatments. So the last case, 56-year-old man who has obesity. Yes. So the question was, it's a pretty straightforward injection. Is there danger in injecting the some of the tendons, gluteal tendons in that area? It's really hard to inject a tendon. So you're really not going to be able to inject it because there'll be so much resistance. So I agree. It's a very straightforward, it's one of the easiest injections there is. And I don't worry about injecting into the tendon. So third case, 56-year-old man, obesity, diabetes, diabetic neuropathy, coming in with posterior hip pain, but he's also got some lateral pain and some groin pain. Started a couple of years ago, no injury. It's worse with prolonged sitting. He says the pain radiates down his leg, occasionally below the knee, and has occasional numbness, tingling in his foot. And this probably, to me, seems like the more usual patient that comes in. Like, it's not straightforward, posterior hip pain or lateral pain. It's like a little bit of everything. So for this patient, I would probably do more of a physical exam, because really what I'm trying to sort out is this coming from the hip or is it coming from the back? So I'll do kind of the tests that we talked about for hip arthritis, the log roll, passive hip abduction. I'll check the range of motion of the hip, and does that reproduce the pain? In someone who's got primary hip pathology, it's probably going to be painful to move the hip around. I'll do a straight leg raise and seated slump test for radiculopathy. I think you all know what the straight leg raise is. And then seated slump test, I showed some pictures over here. Basically, I just asked the patient to kind of slump over like they have bad posture. And then they extend the affected leg and dorsiflex the ankle. And if that reproduces the pain, then I have them look up. And someone who's got kind of radicular symptoms, that's going to improve their symptoms by looking up because they're taking some of the tension off the nerve. I'll also palpate the greater trochanter because they're complained of some lateral pain as well, see if there's some tenderness there. And then, lumbar spine, palpate the lumbar spine, assess flexion, extension of the lumbar spine, and then strength and sensation in the lower extremity. And again, with the flexion extension, does any of that reproduce the pain? So I think that's kind of where the physical exam can be helpful, is like, how can I reproduce this person's pain? Is it moving the hip? Is it moving the spine? That can help you sort of determine where the pain is coming from. So in this patient, what would you guys do next? X-rays, NSAIDs, physical therapy, or work on controlling his diabetes? So most of you would send to physical therapy. Some of you would get hip and or lumbar spine x-rays. And again, I don't necessarily think there's a wrong answer to this question. If the patient has no red flag symptoms, for the lumbar spine, then I think it's probably okay to not get the x-ray. If they've got tenderness along that lumbar spine and they're over the age of 50, again, it's reasonable to get an x-ray of the lumbar spine. And then, whether you're going to get a hip x-ray or not maybe depends on that hip exam, if they've got restricted range of motion, if they've got pain when you're moving that hip around. This x-ray, I just feel like this is the x-ray that we see a lot. Yes. Yeah.
So anyway, I just wonder exactly what you're looking for and how.
Yeah. So the question was, does the x-ray really help in, differentiating between hip or back pain? Because most people tend to have degenerative changes in both and it doesn't really narrow it down. And I totally agree. And that's why I think without red flag symptoms, you don't have to get x-rays. This x-ray right here that looks awful, like really bad degenerative disc disease, has no pain. So that doesn't, so they might have really bad degenerative disc disease, but maybe the pain is still coming from the hip. And same with a hip x-ray. They've got osteoarthritis in the hip, but it's coming from the back. So I think the x-rays here probably don't really help you make that differentiation. Maybe if they come back and they have a totally normal looking spine, but even then you can still have some nerve impingement. So I agree. And that's why unless there are some red flag symptoms that are kind of making me want to get an x-ray, you don't necessarily in this case have to. So that's the question. Is it coming from the hip or the back? And if you're anything like me, this patient comes in, you've maybe gotten the x-rays and degenerative changes in both, and this is how I feel. Is it the hip or the back? So what I usually do is I send him to physical therapy. So physical therapy is going to help it's going to help things from the hip, it's going to help things from the back. And so I have them do 4 to 6 weeks of physical therapy, come back, and then what pain is left. So maybe some of that pain has gotten better and now they're saying, you know what, I'm not really feeling that pain on the leg anymore, and now it's more on the lateral side of my hip. And so in that case, I might say, well, let's try a cortisone injection. That will help hopefully therapeutically and diagnostically. If it gets better when I do that injection, then we know that that's where it's coming from. If they're still saying it's mostly posterior hip, radiating down past the knee, then I'm thinking, okay, maybe this is more radicular type pain. And so if I hadn't gotten an x-ray, I might get an x-ray, and then I would consider an MRI because maybe they would benefit from a epidural steroid injection. And then if they come back with anterior hip, more groin pain that's left over, then similar to the lateral hip pain, I might try a cortisone injection for that as well, sort of a diagnostic and therapeutic option. So to kind of wrap up this talk, I hope that this has been helpful for you. And I just want to go through some of the things that I hope you'll take away from it. So the location of the pain in the hip can really help you narrow your differential. You know, we talked about anterior hip pain being often osteoarthritis, lateral hip pain is often greater trach pain syndrome, and then posterior hip pain often is more radicular pain coming from the lumbar spine. You can also tailor your exam to the suspected diagnosis. You know, sometimes patients are coming in just for their hip pain, but a lot of times they're coming in for other reasons and they mention their hip pain, so you don't have time to do all the extensive hip exam maneuvers that, you know, I learned in fellowship. So I think just doing the few exams that are kind of tailored to that particular complaint can help you be more efficient in sort of determining what the diagnosis is. So, you know, for the osteoarthritis, we talked about the log roll and passive hip abduction and range of motion. For greater trach bursitis or pain syndrome, it's, you know, palpate that greater trochanter, maybe try Faber, flexion, abduction, external rotation. And then for posterior hip pain, you might do the straight leg raise or the seated slump test if you're thinking more radicular pain. And then we talked a little bit about radiographs. For patients who are over the age of 50, I think it's reasonable to get an x-ray. You know, they're probably going to have arthritis in whichever, you know, in the hip or the lumbar spine. But I rarely get an MRI in this age group. So if I get a hip x-ray in someone who's over the age of 50, they do, you know, they've got some arthritis, they do physical therapy, they're not getting better. My next step is not usually to get an MRI because I already know they have hip arthritis. They might also have a labral tear. I don't really care about the labral tear because I know they've got hip arthritis and it's probably not going to change my management. You know, the options for hip arthritis surgically is a joint replacement, and there aren't a lot of options short of that. So the MRI probably isn't going to help you much. But in younger patients who might have impingement or some tendinosis, that maybe when they fail conservative treatment, an MRI might be more helpful. And then treatment was similar for all of these patients. You know, it's activity modification, avoid the aggravating activities, physical therapy, and then steroid injections in some cases can be helpful both diagnostically and therapeutically. Here are some of my references. And I put my kids up here because I love this picture because it really shows who they are. The one on the left is my middle child, and he kind of likes to do his own thing, pretty satisfied with himself over here. And then my oldest just is adoringly helping the younger one, and she's just kind of soaking it all in. Anyway, they helped me. They helped be my audience while I was preparing for this talk, and I'm really appreciative that you guys came today. I really hope you learned something. I'm happy to take any questions. I'm sure there are some questions online. Mm-hmm. So for the hip, I do, and I have to think about how it actually looks in Epic, but it's like I'll do the right hip with AP pelvis. So there's an option to do AP pelvis with the right hip, and that usually includes a frog leg and the AP pelvis. So it's 3 views, the AP pelvis, and then 2 views dedicated to that one hip. So I think that's, you know, right or left hip with AP pelvis. And then for the lumbar spine, it kind of depends. I used to just do AP lateral, but I started doing more. I started doing flexion and extension, which is the 4 views of the lumbar spine. But I don't think that's probably sometimes that's just because I think maybe the PM&R folks might want the extension and flexion. So I think you're probably okay just getting an APN lateral on the lumbar spine if you're, I get all the information I need from that. Yes, and it's just the pelvis. So I'm not getting both hips. I'm getting the pelvis and then dedicated 2 views of the affected hip. Yes. So yeah, there is some, concern that, so the question is, should we avoid corticosteroid injections in certain patients because it might affect the cartilage? And yeah, there definitely is some concern that steroids can soften the cartilage. The people I'm doing hip injections in have arthritis, so I'm probably not going to make it that much worse by doing a steroid injection. But there has been some data that came out recently showing that if you do more than 1 or 2 intra-articular steroid injections, you can actually increase the risk of infection post arthroplasty, so post joint replacement. Now that's like hard data to hear because there's so many people that are just not ready for a joint replacement, and so they get injections for years. So it hasn't necessarily affected my practice. I think we probably need some more data on that, but that's just another thing to keep in mind. Another reason we don't want to just do injection after injection after injection. Yes. I do. So the question was, it takes a while to get into PT. Are there some things for greater trunk pain syndrome that you can have the patient do sort of in the meantime, some home exercises? And I actually have this great book. It's like the patient advisor for all things sports medicine, and it has handouts on many MSK complaints, including greater trunk pain syndrome. So it gives you like a 1-page description on what it is, and then it gives you some exercises that they can take home with them. So I actually usually just make a bunch of photocopies and give those to patients. So if your clinic has that book, that's very helpful. And then there are some up to date sometimes has some exercises. I actually don't know if they have it specifically for that. But the things you're going to want to do for greater trunk pain syndrome is strengthen the gluteal muscles, which is like clamshells. You're going to want to stretch out the IT band, which they can do using a foam roller. They should avoid rolling right over the greater trochanter because that can aggravate it, but just distal to it can help stretch out the IT band. Maybe those would be 2 good exercises to give them in the meantime. Yes. So the question was, is there a way to distinguish between piriformis syndrome and sciatica? So piriformis syndrome, for those of you who don't know, can be inflammation of the piriformis muscle, which I showed you at the beginning of the talk, where that's located in the back of the hip. And it can sometimes put pressure on the sciatic nerve and cause sciatic type symptoms. It's not very common. There are some people who have a sciatic nerve that goes right through the piriformis, and maybe in that person, it's more likely, but I very rarely diagnose piriformis syndrome. So I always assume that it's radiculopathy unless they come back and things aren't better. Maybe they're really tender in that area. So that might be a way to kind of help differentiate is some tenderness in the piriformis area, although I find that people with radiculopathy often have tenderness too. But I would just say it's not very common. So the question is, in a patient who has FAI, femoral acetabular impingement, and maybe a labral tear, is there a risk in kind of letting the labral tear sit there and potentially get worse? And what does that time frame look like? It's a really good question because patients ask all the time, like, well, it's torn. Is it going to get worse? Shouldn't I get it fixed if it's torn? There are a lot of people who have labral tears and no pain. And so just because you have a labral tear doesn't mean you're going to have pain from it. And so I don't really worry too much about how long somebody goes with a labral tear. I usually use their symptoms as a guide in terms of what the next step is. So I think physical therapy is always reasonable as a first step. I don't think it's dangerous to wait 6 weeks before they get imaging. So I very rarely get an MRI if I can avoid it until they come back and say they're not better.
I got kicked off 3 weeks ago. But the first one is there another person near the sacral nerve?
The question is there another bursa by the sacral nerve, sciatic nerve maybe, that can cause pain in the back? There are bursas everywhere. So I think the answer is yes.
Sorry, so a question about controversy regarding surgery for FAI. Get away about
so the question is what my thoughts are on who might be a good surgical candidate for FAI and labral tear repair versus who is not. I think it's just a discussion with the patient. So first of all, before I even have the discussion with them, they have to have failed conservative treatment. And then the question is, okay, because a lot of times the people that want surgery want it because they want to get back to their running and it's 9 months before you're back to doing everything you want to do. It's a very long recovery. And you can't even really promise that you're going to be 100% after that 9 months. So if you're willing to take that risk, then, give it a try. And maybe they're suffering so much that it's worth it. Other people, I might say, hey, maybe we can try a steroid injection and see if that helps and how long it helps for before you consider doing surgery. And I would probably, in a young person who's got a normal looking x-ray and no arthritis, I would probably do 1 steroid injection and then that's it. I wouldn't repeat it. But I think it's a hard question. I think it's really a discussion with the patient on kind of how bad their symptoms are and what they're willing to kind of do to fix those symptoms. And most people, when they hear I'm out for, they think they get surgery and they're kind of better in a few weeks, but it's months and months of rehab. And so I think just being really honest with them about what that would look like.
Question about general thoughts that you have about sports hernia.
Oh goodness. There's a reason I didn't talk about that. So the sports hernia, which we actually aren't calling sports hernia anymore, but I still use that term because I feel like that most people understand that. So the sports hernia is like the black box of groin pain in the athlete. And within the last several years, kind of the sports medicine societies have tried to change the terminology to really describe where that pain is coming from. So instead of the term sports related or sports hernia, we'll say this actually seems more like adductor related groin pain. So when I test resisted internal rotation of the hip, they have pain, they're tender on their adductors. This is probably more adductor related pain, groin pain. And that's encompassed within sports hernia. Someone who maybe is tender on the pubic symphysis, they probably have osteitis pubis, and maybe I can see that on x-ray too. So that's like pubic related groin pain. And then maybe, they do a half sit up and they have pain, and they're tender on kind of their distal rectus abdominis. So that's more like rectus abdominis related groin pain. I mean, sports hernia is a collection of various pathologies. And what I try to do is really zero in on what is it in that area that's causing the pain. Is it the adductors? Is it the pubic symphysis? And then that's how I decide what the next treatment is. I mean, most of the time it's physical therapy, but what is the physical therapist going to kind of focus on? It also requires a lot of not doing the activity that they want to do. And then imaging, you know, if they've failed physical therapy and kind of relative rest, then MRI, you can get an MRI to kind of further evaluate those structures. I don't know if that was helpful. Hopefully it was.
I have one question. I had a patient recently, a woman in her 60s, chronic lateral discomfort that pain, but I wondered, could she have had lateral femoral nerve entrapment? How do you think about when is that injury?
So the question is, someone who's got lateral hip pain, you know, when do you consider maybe lateral femoral cutaneous nerve entrapment? And that's going to be more like numbness, tingling. So maybe pain, but they're going to have more like paresthesias, and it's going to be more anterior lateral thigh and less like directly lateral hip pain that's tender when you push there. And it also depends on what does that patient look like, you know? Do they kind of look like your typical like big belly that could be pushing on the nerve? Are they, you know, it sounds like they're in their 60s, so they're not pregnant, but you know, are they wearing tight pants and those sort of risk factors that you think of with lateral femoral cutaneous nerve impingement? All right, thank you.